In this episode, I interview Instagram famous and ACL Mastermind Dr. Wesley Wang, physical therapist from the East Coast in Maryland. We talk all about ACL rehab. We talk about some general time frames, criterion-based rehab, and most importantly, what we think some of the biggest pitfalls in ACL rehab are. Wesley really strives to make sure people are 100% back to return to sport and that we're not clearing people too early. The rate of second ACL injury, whether it be ipsilateral or contralateral side, is upwards of 20 to even 25% in a lot of the research. And Wesley is really trying to lower that number, not just for himself and for people around him, but for us as a field. If you work with ACL rehab patients, if you work with any sort of end-stage rehab, whether it's even not ACL, this is a great podcast for you.
The Prehab audio experience will teach you how to take control of your health through knowledge by optimizing performance, promoting longevity, and keeping your movement system in tune. Welcome to your host, the Prehab Guys.
So joining us today on the podcast is Dr. Wesley Wang. He's a physical therapist in Rockland, Maryland. He treats a ton of sports rehab patients and in particular ACL reconstruction. On Instagram, you can follow him at wesleywang.dpt and he posts a ton of good content. Again, all sports rehab, but in particular ACL reconstructions. And that's what we're going to talk about today. I'm super excited to have you on. I've learned a lot from the stuff that you posted, especially in your mastermind group. Wesley, welcome to the show.
Appreciate you having me, Mike.
Yeah, so let's do this. Let's just get into it. Why ACL? Why is that something that you're so passionate about treating?
I guess the backstory is the fact that I've never really knew about physical therapy in the first place until I tore my ACL myself. I was lucky enough to have pretty good care. I went to a pretty sports oriented place and just kind of going through that process of, unwrapping my knee for the first time, seeing like all the blood and all that kind of stuff, and just working through that entire process was like really special and really cool to me. And luckily, I had a really great therapist, and her and I really connected. And I think I went into for her, I would go to PT in the morning, and then I would go to my regular desk job for a while. And I was kind of reflecting upon the fact that like why am I going to this job that I hate? And this PT loves her job. So just doing some soul searching and all that kind of stuff, I decided to give it a go as far as the field goes. And then after being in the field I graduated in 2015, so it's been 4 years now. I've just seen so many ACLs and just the lack of care and the lack of education when it comes to this field, and people treat it as if it's just some generic basic injury, like a minor injury and stuff. And we all know with the amount of research out there that this takes a long time to recover fully. And then, nowadays the research supports the fact that re-tear rates are, 1 in every 4 to 5 kids are re-tearing. And I feel like there needs to be better questions asked about why re-tear rates are so high. So I guess that's for me why I care so much about ACL rehab.
Yeah, so let's go. I couldn't agree more. I was talking to one of the kids who's been pushing to get back early, and I told him that stat. He's like, "What, 25%?" I'm like, "Yeah, man. Like, there's a reason why I'm not just letting you go back willy nilly. Like, you're not ready yet. It's that simple." And for like you said, I think there's just people that think, it's just an ACL. I think it's because it's so common and it's so popular within, the media that people just kind of brush it aside like it's some easy thing to get back from, or it's just something that everyone kind of gets back from, and it's not, unfortunately.
Yeah, I definitely agree with you.
Yeah. So speaking about, I guess these re-tear rates, what are some of the reasons, and you already alluded to it a little bit, why you think these re-tear rates are so high, especially in our youth athletes?
Yeah. So I've posted about it before, and I think a couple of big ones, it comes down to lack of care or quality of care, in my opinion. I think there's really no education when it comes to ACL rehab. You can be first day on the job as far as PT goes, and then they give you this protocol that the surgeon has, and then you're kind of told to blindly follow the protocol, and that's going to get the backs all the way. I think another thing is that surgeons are releasing people too early. A lot of kids will come into me, they tear their ACL, and then they go to 3 different orthos getting their different opinions and stuff, and then one guy will tell them 6 months, second guy says 6 months, and then the third guy says 9 months. Like, they're not going to choose a 9 month because 6 months sounds better. And I feel like that's a big problem. I think another one is also insurances. They cut people off at 4 months, and a lot of PT facilities, if they don't have the ability to do that late stage rehab, they kind of just like, okay, you're off doing it on your own. So in my opinion, those are kind of the three major reasons. I do think the average physical therapy facility doesn't have like the space, maybe the equipment to really perform that like late stage reactive stuff that helps with like the proprioceptive side and the confidence side of things. So I guess those are probably 3 or 4 major reasons about why I think re-tear rates are so high.
Yeah, I mean, especially in certain areas. I mean, we're out in LA. I'm on the west side. The amount of clinics, which is very small, that have this space, just a space. It's so expensive to live out here. Just a space to have that much, to be able to actually run and actually reach, full speed. There's almost no places on the west side. I'm very fortunate. I'm inside of a gym, so we have space. We have all the equipment that I would want within the gym itself, and then I can go outside to do all my running. We have like a bunch of tennis courts, so that's usually where I'm doing that stuff on. But the space is huge. I think, like you said, the therapist's knowledge. I think that's one thing too, and knowing when to, refer out if it's not referring to another PT, or at least referring out to a strength coach to help you with that, with that transition, like it would be maybe in the college ranks.
Yeah, definitely. I 100% agree with you on that.
Yeah. So let's go. I guess let's focus on this more at this end stage, especially if we're identifying that it's kind of it's a problem right now, part of these high re-tear rates. So going back to, I guess you could say clearance for kind of this return to participation, like when I shouldn't say when, I hate that question, but how are you making those calls, talking with the physician, talking with the patient, what things are you looking at to feel more and more confident on progressing someone across that continuum?
Yeah, I think a few of the big things, like we know the research supports the fact that you need to have 90% quad strength. But at the end of the day, like I think these Biodex machines are pretty hard to come by. And they cost, I don't even know, like $20,000, $30,000 or something along those lines. So even with that, I think that if you can have a relationship with a facility that has one, that would be a great place to start. But if not, I know there's people out there who have like figured out ways to like rigor up their own, kind of like Biodex testing for IsoConnect testing. So that's definitely one of the bigger ones. I would say also passing the hop test. I think that's a big one too. That's not really done enough, and that can be done in any facility, regardless of whether or not you have a Biodex in the first place. That's probably the two like more like quote unquote standard tests. And then you're looking at the single leg drop test. You're looking at the vertical drop test also to see if their knees fall in the valgus. Are there any shifts? And as I guess maybe some people probably wouldn't love it too much, but I think passing the eye test is important. Yep. If you have that facility, when you're doing reactive stuff, does the athlete even look like they feel confident in their knee? And I think addressing the psychological side is equally as important. I give all my athletes the ACL RSI, which was kind of designed to test the psychological side for ACL patients. And they're pretty generic questions that ask, how confident you are on a scale of 0 to 100 in your knee, performing sports specific tasks, like how worried are you that you're going to re-tear, things like that. Maybe questions that aren't asked enough, but making sure that we definitely do ask them is crucial to make sure that, it's not just a physical injury, it is a, mental side just as much.
Oh, yeah. I've just started using the ACL RSI, started a couple months ago. I guess one thing for me is I don't have a cutoff that I'm using. I remember I was at this ACL talk and it was low. They were saying it was like in the 50s. But what do you like to see when you give that, that questionnaire out?
Yeah, I treat it as if it's the hop test and
yeah.
They want 90% for everything. So when they take the ACL RSI, I want to see them 90 and above. And I think there is definitely a correlation, as they get physically stronger and they start feeling stronger, they're going to start feeling more confident in their knee. So there is usually, if you're kind of looking at how strong they're getting and the ACL RSI, like you're going to see a pretty good correlation between the two. And if you're seeing some like yellow flag out there where they're testing strength wise at 80-90%, but they're grading themselves at 40-50%, then I think having a discussion with the athlete is going to be important. Maybe bring in a sports psychology if we feel like it needs to get to that point. But I just feel like this level of injury needs to be individualized, but most facilities treat it as if it's generic injury. Give them the protocol, follow the protocol, and you'll be back to normal in no time.
Yeah. It 100% has to be individualized. I was having a conversation with a local physician around here, and he was just asking for little bit more clarity on the whole return to sport, side and what things that we may be doing at that stage. And I'll be honest, I was like, it's so different for each person. Like in the early phases, yeah, we had things. Okay, I want knee extension by this point. I want flexion by here. I want the quad to be around this number by this point. They're generally getting into plyos at this point. But when it comes to anything 5-6 months out, it looks so different based on the person. So it's really hard. That kind of goes to what you said, the whole eye test thing. Like you kind of, and you said people hate it, but it's like you kind of know who looks good and not kind of, who looks good and who looks confident in and out of their breaks and then that cuts and who doesn't, regardless of what the other, objective measures would say. Still do them, but I definitely agree with that.
Yeah, 100%.
So basically timeline. So a lot of people will ask the timeline thing. I mean, I've heard you mention a lot of times the 9 months. Do you want to go ahead and let our audience know kind of where that comes from, where the research has come from, and how you have that conversation with patients? If they went to that, some other surgeon says, like, 6 months, you'll be back. 5 months, you'll be back. How are you having that conversation with your patients?
Yeah, so I can't remember the article specifically off the top of my head, but there's an article posted about the fact that like every month you go back early before 9 months, you are at 50% more likely to re-tear. And I think that for me, it's pretty, I don't really try to sugarcoat anything. I think the first time I talk to an athlete, regardless if they're like first week out or if they're 7 months out, I tell them that it's 9 months like minimum for me. Just because I tell them there's so much to work on in that time frame, and I can't even guarantee that people are going to get back at 9 months.
Yeah.
Like even recently, Teddy and I had a girl who plays Division I soccer, so super high level athlete, one of the fastest girls to come to the door at Healthy Baller. She had like a little bit of complications early on, and we didn't clear her until I think it was like 17 months, 16, 17 months. And it wasn't because of lack of effort or anything like that. It's just, unfortunately, it's the card she was dealt from surgery and everything like that. Like she developed a quad inhibition, which is super rare. And that's kind of the reason why I'm so, I emphasize so much that it needs to be individualized, because if this girl just went to some generic place and followed some protocol, like I don't even know where she would be at right now. So I definitely kind of sometimes will paint these pictures for these kids. It's like, I see these all the time. So you need to kind of trust the process that needs to be 9 months. And I think my big thing, I always tell every kid that we are focusing on the big picture. A lot of times I'll ask them what their end goal is. And, a lot of times it's like, a lot of these kids that I see are trying to play college soccer, college lacrosse, whatever it is. And I'm like, do you want to put yourself at risk to go back a month or two early for the sake of playing in this season? Or do you want to be playing all 4 years of college healthy without having to deal with a second tear, And most of the time they listen. I definitely have athletes from time to time that don't choose to listen. I had a girl recently that she wanted to play club soccer, didn't really want to hear what I had to say necessarily, and she decided to play early. So I think it's definitely dependent, but I would say the majority of the athletes that come to the door for me are pretty open-minded as far as listening to waiting until I clear them to play.
Yeah. And is that clearance, is that mainly you deciding that, or are you working with a lot of the physicians in your area? How does that, how does that work for you?
It definitely depends on the surgeon. It's funny because, just recently, early on in this podcast, I was talking about how there are some orthos who clear people at 6 months. So those are the ones that are trickiest, because I tell them very, like, I can almost, at least the orthos in our area, I don't want to go out there and, hate on orthos, because I know there's great orthos out there. But I spent 2.5 years working at orthopedic surgeons, and I told them, I was like, who spends more time with you? Like, do you spend more time with me on a regular basis, on a weekly basis, or do you spend more time with the ortho? And the majority of the time, you walk into the ortho place, the ortho kind of looks at your knee. They might bend your knee a little bit. They maybe will have you do a squat. They look at the knee and they're like, yeah, this looks great. And then you're at 6 months out to play. And I'm like, I'm the one looking at you squatting. I'm the one looking at you cutting and decelerating, change of direction, cutting, all that kind of stuff. So I was like, how does it make sense to you that they're clearing you? And it's, so I kind of like do paint this picture for them. And a lot of times they do realize that I'm the one looking at them on a weekly basis. So I think sometime painting that picture allows the patient to realize, like, oh yeah, maybe it should be the therapist clearing.
Yeah. Yeah. And thinking about the whole big picture of things, and then working with these athletes, I think that's important. Like you said, talking about their future goals, like, well, what's more important, this one game of club soccer, whatever it may be, or your potential future collegiate and maybe even professional career. Who knows? So
yeah, definitely.
What are what are some of the biggest tools, modalities, things that you incorporate within your ACL rehab, either for yourself as a clinician or things that you're telling patients to get or use or buy or whatever it may be?
I'm not too big on like buying too many tools, to be honest. Like even early on, like I'll just have people get a stretch strap early on just to help with like the flexion and the extension. That's why one of the bigger ones I'll have them do. But I'm not really big on having people buy like a cryo thing or anything like that. I'm like, if you want ice, just put some peas on it,
Yeah.
I think a stretch strap early on is definitely the biggest thing. At least for me, and I recognize that I'm in more of like, I guess, a unique setting. But if there's a kid who's super bought in, and they're able to come in 3 days a week for late stage rehab, I actually don't have my kids do anything at home. I think if I'm loading them really well, Monday, Wednesday, Friday, they don't really do much at home. Yeah, they can do like a little bit of bounding for neuromuscular control stuff. They can go outside for light jogs, maybe depending on where they are in their progress. But I think if they're being loaded well enough in the facility, there shouldn't be a need for too much like buying equipment at home or anything like that.
I agree. And then early on, though, you're saying for the range of motion, maybe a stretch strap. And then, I guess while we're on range of motion, what are some of the time points? I know it's going to vary on so many different things, but that eventually that you want to see full extension or full flexion or near full flexion.
Yeah, I think ballpark, hopefully within the first 6 weeks is ideal. If you're like 85 or so % there, I'm by 6 weeks, I'm usually pretty happy with that. I think range of motion is a little bit underemphasized early on. Like I tell my kids that I want them doing it 5 to 6 times a day, so they understand the volume that they should be doing it. And then in addition to that, a lot of these kids are in school. Like I was like, when you're sitting at your desk, just move your knee back and forth. Like you don't have to like go extremes or anything like that, but just keep that thing moving. I also tell them like, I literally tell my kids I want them doing hundreds of quad sets a day. So again, they understand the importance of getting that quad back. And I really try not to do anything too crazy early on. Like I'm not really worried about doing bridges or clams or anything like that early on. Like I want to see you get full range, flexion, extension, get that quad woken up, get that swelling down in the first 6 weeks. That's the biggest priority. And if you're recovering really well, okay, yeah, then I'll start throwing in the bridges, the clams, and all that kind of stuff. But I just feel like if you set that foundation right for the first 6 weeks or so, that really just sets the tone for the rest of rehab, in my opinion.
Totally agree. And I think what you mentioned about the education, I think that's so important, letting the kid know, hey, look, it's going to take this much volume every hour, every 2 hours, this many times for the first, however long it may be, and knowing what their goals are. Your goal is to get your knee straight by, this week. Like you said, it sets the foundation. So now they know what's important, and they're not just overwhelmed with, like you're saying, all these different things that they had to think about, let alone they just had a surgery a couple weeks ago.
Yep, definitely.
That's huge. Yeah, education. Let's see. We pulled our followers. I got some questions. I'm going to start looking through some of them. What are your thoughts on the whole open versus closed chain for early ACL rehab?
Yeah, I know there's a lot of like mixed research behind it. And I think for me, I'll do like short arc quads with a little bit of weight fairly early on. I tend to leave the full long arc quad until about 12 weeks. I kind of got that from Lenny, who I respect as a physical therapist. I know that some people go full range early on, full range as far as like the full long arc quad goes. And, I think at the end of the day, there is pretty inconclusive evidence behind, are you overstressing the tissue or anything like that? And to be honest, I also think about like when I had ACL surgery, like when I was sitting at my desk, was I probably doing a long arc quad? You know what I mean?
Yeah, like all the time.
So unless they're being deliberately told not to, and even then it's somewhat of a fairly natural thing to just kind of like, if you're sitting in class for a while, to just like raise your knee up. And I just feel like it's with what kids are going to be doing on a regular basis. Maybe they're going downstairs a little bit too early. Like they're already stressing the knee more than probably a short arc quad is doing in the first place.
Yeah.
So that's usually my argument for doing open connection. But I feel like regardless, it definitely has to be utilized at some point in rehab, just because it rounds the quad every way possible, open, closed chain. all different planes of motion. It needs to be challenged in order to get that thing all the way back.
Yeah. And I mean, that's my opinion of it too. Like, you have to be able to isolate it. People are going to cheat. Even if you tell them exactly where to put the weight, even if you put up all the external loads in the right place, people are still going to find ways to not use their quad or shift to the other side or use the hip or something. With the open chain stuff, you can still cheat, but there's still a lot less cheating that's going to happen.
Yeah, for sure.
I know for me, and I've seen you using a lot of BFR, because with BFR, the loads are so low that I know me personally, I'm not too concerned about the open chain stuff early on, because I'm like, they don't even have a weight on their leg. They're just moving through the range of motion, which is kind of like you're saying, what they're doing normally throughout the day. And the loads just on stairs, getting in and out of chairs is way more than what the stress is going to be on the graph at that time point.
Yeah, definitely.
We have another question here. I don't know why. It must be a lot of people with partial ruptures. They had a lot of people ask what to do if I have a partial rupture. So if you're getting those people in the clinic, maybe they come to you first before seeing anyone else. What do you think? We'll go partial, and then we'll go a full tear. You're the first line.
Yeah, I think it definitely comes down to quality of life, and I think also how big the tear is probably the two biggest questions to ask. So I actually have a partial tear myself on my left knee. That's not the one that I had repaired years ago. So it's been about 7.5 years now, and more or less I'm fine. Like, I literally, I told you earlier that I play basketball today.
Yeah.
So I definitely have had to modify the way that I play. I'm a little more conservative than I used to. Yeah, I used to be. And then also I used to play like flag football, and I gave that up just because of like being on uneven surfaces and all that kind of stuff. And I feel like with football, it's a little harder to protect yourself. So I made the decision of just giving up football and just sticking with basketball. And I'm perfectly fine. I don't really think about my knee too often unless it's in some weird position in basketball. But 95% of the time, I'm pretty confident in my knee. So I think that's definitely the two bigger question that someone needs to ask themselves. Like, if you're going upstairs and you're turning around the corner to go to your bedroom and your knee buckles on you, then that's probably a little bit different. But if you are, in your low to mid 40s and you're pretty strong and you just want to go hiking and light jogs and things like that, then, I think that is perfectly fine to just go non-operative.
Yeah. Are you seeing a lot of non-op in your practice right now?
Definitely not that common.
Not that common.
I want to say I've only had like one, and he was an adult. I think he was like mid to late 40s. He didn't do any cutting sports. He did, I want to say like kickboxing or something like that. So It wasn't super aggressive, and he was strong. Like, he's a strong dude. And I told him, I was like, if I were you, I would forego surgery. I would stick with just like really aggressive strengthening. And he owns a gym, so he knew what he was doing.
Yeah.
So he was like an easy candidate to just be like, yeah, don't worry about surgery. And as far as I saw him for like 2 or 3 visits, and as far as I know, he's back doing what he wants to do.
Nice.
Yeah.
Nice. Yeah, I have one right now on my schedule, and she's doing really, really well. Same thing, just not trying to get back to any level 1 cutting sports. Kickboxing, surprisingly, is the most, I think, rotation that she'll have through it, and she looks really good.
Yeah.
And it always makes me think. It
definitely comes down to how big the tear is, and like what you're like. If it's a full tear and you're trying to play like Division I soccer, like that's probably not going to be the best decision.
Yeah. It always makes me think, because I know in my before it came here, or I would say even a lot of the people I see now, I do have a good fair share of youth athletes, but a lot of these people that I have on my schedule are probably in their late 20s to 30s. So these people aren't necessarily collegiate athletes, maybe slight weekend warrior, but they're not really doing pivoting and cutting sports all the time. And I always think like, well, I wonder what would have happened, if they didn't get the reconstruction done. Like, how would they have looked? I'm thinking of a couple girls that I had before that I luckily did prehab with them for about 2 months, and they looked amazing. Like, they were killing it. And then but because of how good they were, of course, they killed it afterwards too. But I'm like, well, what if they didn't get it? Like, could they have been killing it too? It's always a thought that I have in my head.
Yeah, definitely.
Cool. Let's see. I got another question. So what are some of your ways or things that you tell patients that still have BTB, like site morbidity? So if they're taking like a patellar tendon, maybe these people still have pain with kneeling, What are some of your strategies, I guess, that you use to help these patients?
Yeah, that's especially with the patella graft, like the likelihood of having some sensitivity on that scar is pretty high. Like I'm how far am I out? Like 9 years out from surgery, and even then kneeling on it, like I don't I don't like it doesn't hurt or anything like that, but I would say it's sensitive. Is probably the best word for it.
Mm-hmm.
I sometimes I explain like at the end of the day, like it is a very major surgery, and like if you haven't seen like an ACL surgery before, if you just YouTube one, like you kind of see like the carpentry work that they end up doing. Uh, it's aggressive, you know. So I think at the end of the day, like if it's not like super painful, then I don't worry too much about it. Like I just tell them that I think it's probably going to be there for a while.
Mm-hmm.
If it's like actual like patella like tendinopathy at that point, then you're looking at like, are you overloading? Do we need to back off of things a little bit? Do we need to go back to isometrics? But I think if it's just like sensitivity with kneeling, then gradually introducing kneeling is going to be big. Like maybe having them start in like a quadruped and start with not in their entire weight, and then gradually going back into like kind of a child's pose where you're loading more and more. That's probably the best way to get that thing used to doing it. And I've had some people doing like I don't know if it works for everybody, but just using like a towel and trying to desensitize a spot. I know that sometimes people do that as well.
Just rubbing it with different stuff, essentially.
Yeah.
Yeah. I think it's just trying to get them used to kneeling, like kind of like you say, just gradually apply, and hopefully they get desensitized over time with more and more kneeling.
Yeah, and I think early on, I do tell people that it's almost to be expected that it's going to be sensitive.
Yeah. It's unfortunate, but yeah.
Yeah.
Let's see. There's two other good ones here that I really liked. What are some of your tips early on to get the effusion down that you're telling patients, whether it's what the activities that they're doing or telling them things not to do, or things that you do in the clinic to work on those first couple of weeks?
Yeah, it's with swelling it's definitely tough, and I feel like sometimes people just have bad luck in a way.
Yeah.
I think, like you said earlier, like you did prehab with people. I think getting swelling down during the prehab is super, super important. In addition to full range and quads and all that kind of stuff. So I think getting swelling down early on is a really good way. Like prehab, getting it down before surgery will help a lot with the post-op surgery, post-op swelling. And I also tell them, in addition to what I said about doing range of motion 4 to 5 times a day, like if you can elevate 4 to 5 times a day, that would be ideal too. Like if you're sitting in class, ask for a chair so you can elevate your foot so it's not, constantly putting down the whole time. And I know that we want to definitely encourage some walking for kind of that proprioceptive feedback, but don't go crazy with the walking. Like don't go out there and go to the mall and shop for 4 hours. You know what I mean?
But I'm in high school. I like it.
Yeah, I mean, you're surprised. Like it does happen, but people don't think about it that way. They're kind of like, oh yeah, I feel pretty good with walking. It doesn't hurt.
Yeah.
It's like it's always about the pain. Like you're still in a position where blood's just kind of going straight down to your knee. Like if you can get that thing up, that would probably be more ideal. So that's probably the two different ways of getting the swelling down before surgery, and then after surgery, making sure they're elevating 4 to 5 times a day for 15, 20 minutes at a time, especially at the end of the day, because that's when they're probably going to be the most swollen.
Yeah. Let's do this. We'll do one more. Don't want to take up too much time. I know it's late for you right now on the East Coast, even though you said you're a night owl.
Yeah.
I had a lot of questions, and I'm just going to put it onto one. Again, we talked kind of about time frames earlier. Generally, we talked about range of motion, saying about 6 weeks. But when are some of the times, and how are you going through your progressions of, let's say, jumping, we'll say running, pivoting? Like when are you adding in other variables into your your movement skills? And in ideal, non-complicated, been with you since day one, everything's going smooth. Like what are your kind of your time frames that you're kind of looking at?
Yeah, if you're painting a picture perfect scenario for me, which again doesn't really happen too often, unfortunately, because you're talking about again, this is assuming no meniscus involvement, because that alone will slow things down early on. But if it's just a clean ACL and they did prehab with me and they're crushing rehab and stuff, full range by ideally 6 weeks would be awesome. Starting at about 7 to 8 weeks, if they look good, then we're starting to work on that kind of deceleration work where I'm doing like med ball slams, step offs, working on the deceleration that way, split squat, med ball slams. I usually will always do like absorption activities first to make sure that the knee's not stiff. And then once you're getting to about, 12 to 13 weeks, if everything's clean, then that's when we can start jogging. But again, I think everyone's so like excited about jogging and like they think that that's like the best thing in the world. And I understand it. Like I was super excited when I got to jog. But even again, like once you start jogging, like you have to make sure you're not going out there and jogging for 4 miles a day, which does happen because you're so excited to run. I think, and then after that, let's say 4 or 5 months ish, that's when you're starting to work on like the actual deceleration, like running and slowing down, before you really work on like sprinting. Like I always make sure they can stop before they can accelerate, and then once 5-6 months, that's when you're starting to work a little bit more on like aggressive plyometrics, single leg plyometrics, cutting, change it really more aggressive change of direction. And then from that 6 to 9 month time frame, if assuming really good recovery, like it's like a normal, quote unquote, normal lifting session with the intent of really loading the quads, hamstrings, glutes, and really building their confidence during that time frame for their position, sport, making sure you're keeping all that kind of stuff in mind.
Wow, I think that was super helpful for a lot of the people that listen to the podcast. That was a lot of the time frame stuff. Like you said, it's hard because no one. It depends on so many variables, but I know people will appreciate that.
Yeah, it's funny. Like on my, I definitely don't. I mean, I guess I do it intentionally, but a lot of people on my videos, they'll ask me like, when can I do this or when can I do this? I'm not gonna lie, I just ignore them. I'm not trying to be rude, but it's like
I know. I don't know you.
I always put it in my post. I'm just like, I can't tell you when it's gonna be, because if I tell you 12 weeks and you're not doing it 12 weeks, then you get mad at me.
Exactly.
So I just stay away from timelines. Really, I haven't looked at a protocol in forever. Like when I get a patient, all I really care about is what's your weight bearing status as far as your ortho goes, because I want to be respectful to that.
Yeah.
And if you had a meniscus repair, obviously like that matters too. Like when do they want you full weight bearing? When do they want you off crutches and braces? I am definitely respectful of all that kind of stuff. But as far as like the actual loading goes, like I feel like I have a pretty good grasp of how to gradually load someone without overstressing the knee. And I just think that a lot of those, at least where I worked, the 2 places that I worked, those protocols were so like generic. You know what I mean? Like it's like a 19-year-old Division I basketball player versus a 47-year-old or like weekend warrior type person. Like it can't be like that. So that's usually one of my bigger gripes with these protocols.
Well, I'll be honest, and it's sad to say, I honestly truly believe the reason why there are protocols is so bad PTs don't fuck things up.
Yep. I agree with you on that one.
100% why. Like it's all load management at the end of the day, no matter where they are in the surgery. Like if I ever, I'm knocking on wood right now. I've never had a really big injury, never had surgery, but I wouldn't need to know what. I don't want to say one needs to know, but you can progress your loads based on how someone's responding to the loads you're giving to them, and then make adjustments that way. I think the protocol is just so bad. PTs don't mess things up. Yeah, like, oh, I can't do any of that. Or here's something that I should be doing at this time frame because
it's so tricky because like if you don't have a protocol and you give them to someone who doesn't really understand progressive loading, then it's like they're really in trouble. I fully understand it, but I just wish these things were, and that's my whole thing where I feel like there needs to be better education for ACL rehab, just because like, like why we said earlier, like these retear rates are 20-25%. Like people need to be asking the right questions as opposed to just being like just accepting that statistic. And I feel like that's where we're at right now in our field, is like people are just like, yep, it's 1 every 4 to 5. Like we're that's just what it is. But like I like between Teddy and I and Alyssa just started with us, but with Teddy and I, like, knock on wood, but we're batting a pretty good percentage with all the ACLs that we're seeing. Like I've only had one retear really, and to be honest, I didn't clear her to go back. I didn't feel good about her playing. And I never cleared her, but she decided to go back early. And unfortunately she retore, or she tore the other side, I'm sorry. But overall, like we're batting a really, really good percentage, but I feel like we're just trying to check every single box that we can to make sure these kids are safe to go back. And I feel like unfortunately it's just there's not enough education out there about this big injury.
Couldn't agree more. And now that we're on the education, why don't you tell our followers a little bit more about your ACL Mastermind Group?
Yeah. So I think I felt there was a big void when it came to ACL rehab, and I reflect on when I was a new grad and I was starting at a a typical outpatient ortho place, and just like I was like, did I screw anyone up? Like I really hope I didn't screw anyone's ACL up, and maybe I did, but at the end of the day, like I kind of went through the system as a pretty standard thing, whereas like I graduated, follow a protocol, and then just hope they're safe to go back. And I think that now where I've carved out this niche for myself as far as ACL rehab goes, and I just like why isn't there? That there's other like big physical therapists out there who are also trying to make a difference. Like Mick Hughes has his own protocol, which is more time based as opposed to more criteria based as opposed to time based. And I love what he does. And I know like Steph Allen is a big one, and there's plenty of other physical therapists out there who are trying to like move the needle in the right direction, and this was my way of trying to do that. And basically what it is, it's a mastermind group. So every 10 to 12 days I add videos of content, and the whole program is organized between like early quad exercises, early knee range of motion, flexion extension kind of stuff, all the way to late stage, how I teach deceleration, how I teach change of direction, how I break that stuff down. And this is all stuff that I've learned at Healthy Baller from our strength coaches who are phenomenal. And this is all stuff, in my opinion, doesn't get touched in PT school at all. You know what I mean? And that's one of my bigger frustrations, is that like TheraX in PT school is the most generic thing in the world, at least where I went to school.
No,
and
same everywhere.
Yeah, and that's what I've heard, unfortunately. It's like, what do we do with an external rotation for shoulder, yellow band? Let's go to rep band. There's no concept of hey, what about changing the tempo? That's a pretty big one.
Yeah.
And and there's no concept of teaching like rep ranges and hypertrophy rep ranges and endurance and all that kind of stuff. And I just feel like it needs to be taught, especially when you're dealing with this magnitude of an injury. So that was my whole thing with starting this thing, and overall it's been pretty well received. I have over, I think, 100 different we have like ATs, PTAs, PTs in it, strength coaches, so it's been awesome so far. So I just, and on my like, try to stay on about like adding more content regularly so that people can continue to like learn, and hopefully I can move that needle a millimeter in the right direction. If I can, then I'll be pretty happy with it.
I think you have it. It's a really, really great resource for those of you guys that see his videos online. It's even those, but even way more than that, and a lot more explanation. It's almost like you're learning from Wes, like you're there at Healthy Baller learning from Wes. And I'll make sure we'll make sure to add a link. I'll have you send me a link. We'll add that to the show notes for anyone that's interested in learning more about his ACL Mastermind Group. Let's do this. Let's wrap it up. I guess the one question that we ask everyone is, what does prehab mean to you? And then if you have any closing remarks, and then we'll finish up with that.
I guess with the word prehab, I think the biggest thing is like learning to take care of your body is a big thing. I think we live especially when it comes to like PT and healthcare and that kind of stuff, and these kind of musculoskeletal injuries that we see, we live in a very reactive world. You wait for something to happen and then you do something about it. And again, tying it all back to like what I do with ACL rehab, like I just think it's so like mind-boggling, the fact that nobody does any type of prehab. There's no injury reduction programs being done, at least for the majority of the people out there, and they just like wait for an ACL tear to happen, and then it's like, oh well, we just lost another one, and then you react to it after. So that's, in my opinion, what prehab is. I've heard of some of the girls that I see teammates are tearing in one season. And nobody's really asking the question again, like, why is this happening? They're just like, well, that's unfortunate. But I think asking the right questions and taking like your health into your own hands, as far as like doing some injury reduction stuff. If you have shoulder problems, then maybe keeping your shoulder strong is going to help you stay healthy, as opposed to waiting for it to hurt then go to PT.
Yeah.
So I think that these are definitely big things that can significantly reduce the likelihood of people suffering, these muscle strains or ACL tears or whatever the injury is.
Yeah, and we as PTs, we'd much rather see people on the healthy side of things than in the clinic when you have to quote unquote rely on us because you're in pain or you can't do your ADLs or whatever it may be.
Yeah.
Love it. Any closing remarks or anything else that you want our audience to know? Anything else you want to anything else you want to say?
I think just a big thing. I think that when it comes to like whatever you're passionate about, I've been following you guys for a long time, even before I had any followers, to be honest. And I think that the way that healthcare is going nowadays, like Instagram and that kind of stuff, is becoming so big. So I feel like at least when I was in school, this stuff like Instagram, PT Instagrams were not a thing. So I think like having these like extra resources has been huge. And I feel like if people, and I don't know about you guys, actually, I'm sure you guys do, but like people, I'll probably ask you questions about like, how do you get so many followers and all that kind of stuff? And then I don't know. I think for me, when I started mine, I did it for the purpose of like learning and challenging myself. So definitely for like any young clinicians out there, like if you want to start one, don't start one for the purpose of gaining followers. Do it for the purpose of like challenging yourself and promoting your brand of physical therapy. And at the end of the day, don't be afraid to ask questions and don't be afraid to challenge things. Like even just now when we hopped on, like I think you were asking me like, is there anything I wanted to stay away from? I'm just like, at this point, I don't really care. Like I'm okay ruffling some feathers because I feel like, if you do it in a respectful way, like it's cool because you're trying to, hopefully make change in a positive way. Obviously, if you're being disrespectful, and that's a little bit different. But I think that asking challenging questions to people is definitely an important thing.
Yeah, asking questions and being okay being quote unquote wrong. Learning from it and then moving on to the next one. But yeah, all right, Wes, love it. Guys, on social media, it's at wesleywang.dpt. We'll link to his website as well. The website looks great. I think I told you that earlier. I love the website. A lot of cool videos on there in the backdrop. And then we'll link also to the ACL Mastermind Group as well. Wes, with that, appreciate it. Hopefully you're not staying up too late. and we'll sign off right now.
Yeah, thanks.
That was an amazing podcast. I hope you guys learned a lot about ACL rehab, in particular end-stage rehab and everything that goes into it. Wes is a wealth of knowledge. Please go follow him on Instagram at wesleywang.dpt. In the show notes, I've also linked his website as well as his ACL Mastermind Group. For many early, younger practitioners that may be listening, I know so many things, especially on protocols, all time-based, but I want to get people thinking about criterion-based rehab, as Wesley mentioned. And although we ask for general timeframes of when someone may be running or when we want knee extension or when someone may begin cutting, know that for everyone it's going to be way different. And when we begin those things is when they've hit certain criteria or progressed through their certain exercises or range of motion. That holds true for all rehab, not just ACL rehab. Again, if you guys have any questions, let us know. You can reply back, hit us up on DMs, email us at info@theprehabguys.com. If you guys are listening to this and you really liked it, please take a screenshot of it, post it to your story, post it on Instagram, tag us at the Prehab Guys, and also tag Wesley Wang. Please rate, review, and subscribe to the podcast. It really, really helps us get the word out there. Thanks again. Have a good day, guys.